Okay, well, I want to give a very warm welcome to everyone. I am Brian Shields, CEO of Neurant Medical. This is my voice, although you can't see me. I am delighted to introduce our speakers this evening, Dr. Davis and Dr. Sillers. By way of introduction, of which one is almost not needed for these two folks, Dr. Greg Davis is a private practice rhinologist in Seattle. He's also an associate professor at the University of Washington, where he practiced as an academic rhinologist for over 13 years. Dr. Davis currently serves on the board of directors of the ARS and chairs their rhinologists in private practice section. Dr. Mike Sillers is in private practice in Birmingham, Alabama. He was previously the chair of the otolaryngology head and neck surgery at the University of Alabama. He is a past president of the ARS and served on the Rhinology and Paranasal Sinus Committee of the Academy. We've been very fortunate here at Neurant to work with both Dr. Davis and Dr. Sillers over the last number of years, and they do have significant experience in the use of the Neuromark system in treating rhinitis patients in their practices. So before handing over to the speakers, I want to draw your attention to two things. There's a Q&A section at the bottom of the screen that you should see. This is a moderated Q&A and your question will be visible to the speakers. There's also a resource button available which you can use if you wish to arrange a demo of the Neuromark system at your practice or are in need of any patient-facing resources. This can be clicked throughout the webinar. So handing over to you, Dr. Davis, to kick us off.
All right. Well, thanks, Brian. I'm going to just share my screen here and see if this part of the technology works. There we go. All right. Well, I appreciate the introduction, Brian. And I was going to introduce myself, but you did a great job. And I think you covered Mike as well. So Mike and I are hoping this will be interactive, and we'll do our best to look at the questions as they come in. You can use the Q&A. I'll try to take a peek at them now and then. If I don't get to it, we'll have some time at the end, though. So please feel free to use that. And I'm just going to start off by talking about rhinitis. So, you know, it's strange. I actually gave a talk this morning to a group of allergists in the greater Seattle area. And I stood up there and I thought to myself, why is a sinus surgeon talking about a runny nose? It's just the silliest thing. You know, you think 10 years ago, Mike, 10 years ago, would you have even thought that you were giving a presentation about a runny nose?
No, not at all. We tried to send these patients to the allergist because we didn't have a lot to offer.
Yeah, exactly. So, and then you look at this slide, 25% of Americans have chronic rhinitis. Over 10 million patients seen by ENTs every year with rhinitis. Mike, on a weekly basis, what's your average? How many patients do you see in your clinical practice that have a chief complaint of rhinitis? So not sinus plus a runny nose, just a chief complaint of rhinitis. What do you think?
It's the majority of them. It's a little hard to say that specifically because they don't come in saying I have rhinitis. They come in with maybe other symptoms, and it turns out it's rhinitis related. But I would say it's the overwhelming majority of patients at least have a rhinitis component.
Yeah, and what about chronic cough? Are these patients coming in saying I'm constantly coughing, clearing my throat? Are those rhinitis patients in your mind, or are they something else?
Well, I think some of them are. I think it takes you to the differential of all the things that cause people to clear their throat and cough. Rhinitis is certainly towards the top of the list. I think reflux is the big masquerader of rhinitis, and I think it's important for us to determine which of those patients might be reflux patients and which might be rhinitis. And they actually may be both.
Yeah, very true. Very true. All right. So speaking of, great segue. So there are a lot of different types of rhinitis, and with so many things that we manage on a daily basis, establishing the right diagnosis is key to success. figure out what's going on before you start throwing medications or treating it. So allergic rhinitis, these are the different three main types of rhinitis: allergic rhinitis, infectious rhinitis, meaning purulent sinus disease, and then non-allergic, non-infectious rhinitis, everything else. So drug-induced, NSAIDs can do it, PDE5 inhibitors, some antihypertensive medications can cause rhinitis, certainly hormone-induced rhinitis with elevated estrogen levels. Elderly rhinitis, the majority of patients over 65 will complain of post-nasal drainage. They'll constantly be carrying around tissues stuck in their sleeves. Gustatory rhinitis happens to many of us who eat hot, spicy foods. Occupational rhinitis just means they're exposed to irritants in the work environment, but that can also be other irritants like forest fire smoke, smog, pollution. No one's allergic to those things, but it's a small particle size that causes the rhinitis. Atrophic rhinitis, a total different entity with crusting, obstruction, drainage, dryness, pain, and then finally vasomotor rhinitis. And for me, I think of vasomotor rhinitis, if I had a Venn diagram, it would encompass a few of these. Certainly the hypercholinergic state of elderly rhinitis, eating hot, spicy foods, so gustatory, changing temperature environments, that's not on this list. Hot to cold, cold to hot. And then exercise-induced rhinitis. So that's a kind of a non-specific type of vasomotor rhinitis, but it encompasses about 71% of this non-allergic rhinitis. So it's there. It's pretty common, and it impacts our patients. We're used to treating patients with sinus tumors or horrible sinus infections that need surgery, but these patients come in and they're miserable, 1.5 to 4.5 times more likely to suffer other conditions like asthma, eczema, migraines, and depression. It really impacts their productivity almost as much as chronic sinusitis. And 80% of patients with mild to moderate severe rhinitis have an impairment in their daily activities, meaning it just gets in the way. And I never appreciated this until I started treating these patients and making them or allowing them to feel better with different treatment options. And they come back and they say, "Gosh, doc, you changed my life." And kind of like early on, I was like, really? Like, really? Mike, did you have that experience? We're treating a runny nose. Did you have a couple patients early on that you had some successes with?
Hopefully I didn't visibly roll my eyes when these patients would show up, but at least I did inside my head, because you just felt like, really, your runny nose is impairing your quality of life, and you don't want to go out to lunch with your friends because your nose runs. And those are the things that we would hear for decades, but just didn't pay much attention to because we didn't have a good treatment option. It's surprising to look at these statistics and realize I've somewhat ignored them for the 30 years of my practice.
Sure. Yeah. And so speaking of these, now you have a patient that comes into your clinic, and we know there's kind of four main reasons of rhinitis. You have some anatomic issues. You can have chronic sinus inflammation, so chronic rhinosinusitis, allergic or non-allergic inflammation, which we kind of just covered. And then this neurovascular dysfunction, this neurovascular imbalance. What is your standard approach? Take me through your clinic visit when you have a patient come in. Doesn't matter the age or who it is, but what's your thought process in evaluating a patient with rhinitis?
Well, going back to what I said earlier, and the whole eye roll thing, one of my early professors said, if you listen to a patient long enough, they'll tell you what's wrong with them. And the last thing I've wanted to do is listen to our rhinitis patient. But now, listening, you can get a better idea as to where they might fall in. And they may actually have, components of each of these circles. And so I think you've got to, first of all, nail down their actual symptoms, because when they come in and say, "I've got post-nasal drainage," well, what do they actually mean by that? And sometimes they mean they have a foreign body sensation in their throat, and it's not really anything that they can produce in terms of drainage. Sometimes when it's rhinorrhea, obviously we got to make sure that they don't have a CSF leak. And most of these patients, they say it's bilateral, so that makes it somewhat easy. On your exam, you're going to see clearly evidence of an anatomic issue, but that may not actually be their issue. So when a lot of these patients come in, they've been treated previously. They've had a smattering of intranasal steroids. They've had, most of them I don't find have been ever treated with Atrovent, but they've had nasal antihistamines. They've certainly been on multiple courses of antibiotics. And so when I say that I would go from exam to, which would include an endoscopy, to CT. I certainly don't look at CT as a diagnostic tool for rhinitis, but because so many of these patients are convinced that they've got chronic rhinosinusitis, and I may be convinced that they don't, but they're never going to believe me, I've got to show them objective evidence of it. So point of service imaging is a very helpful tool in sort of taking the symptoms and saying, well, it's not from chronic sinusitis, and you can show them clear sinuses, and you can see the anatomy, and you can have a discussion about what contribution the anatomy may play in that. But that really helps kind of solidify where we are in one or more of these circles at that point.
Right. Where does allergy treatment or allergy testing come into play with this?
You know, I think it's important. In the South, we have such a long allergy season. It goes from February to November, essentially. And again, a lot of these patients have been allergy tested. We did allergy testing ourselves for a while. We did immunotherapy. We currently do not. I've got an allergy group that we work closely with, and they will do the allergy testing and allergy shots and sublingual therapy when it's indicated. So that's one of the elements that you have to look at in terms of objective measures to see. But a lot of them, they've already been treated. You know, as I mentioned, they've been treated, maybe not completely appropriately, but I also look at treatment response. Even if someone does have allergic rhinitis and they haven't been on shots, they should have had at least a partial response to standard medical therapy. So if someone says, I've got allergies, and they've had no response to standard medical therapy, then I'm less likely to believe that this is an allergic condition than if they've at least had a partial response.
Right. Now, you said a couple things I want to pick up on. One was a CT scan, and the other was atropine or hypertropium.
Right.
And I completely agree. Unfortunately, in the past year or two, it's becoming harder for us to get same-day pre-authorizations on CT scans, even though we have a scanner in my office.
Right.
Now, one of the things that I agree with is the hypertropium is a nice test to see, is it vasomotor rhinitis? Because it is an anticholinergic, and it should decrease the postnasal drainage if that's what we're actually treating. So I'll tend to put them on a 3-week course of ipratropium spray, 1 to 2 sprays once or twice a day. I usually pick the higher dose of 0.06%, have them do that for a few weeks. And that gives us time to get the pre-authorization. Then they come back and they get a CT scan. I see them right afterwards. And I 100% agree. I do get a CT scan on these patients, partially because in some of the research studies we've done with this and other devices, we found about a 15 to 20% incidence of chronic sinusitis in these patients. And that's important to obviously diagnose. But just as you said, Mike, it's important to convince them that, hey, your symptoms are not a sinus infection. You don't need antibiotics. We're not treating an infection. We're treating an inflammatory or a neuromodulation.
Right.
So I agree with you on that one. All right. Just a quick little anatomy. This is, we're talking about the posterior nasal nerve. That's a postganglionic parasympathetic nerve that comes out. We used to think it came right out of the sphenopalatine foramen. Now here's the sphenopalatine artery. You can see my little cursor circling it. And we used to think there was a nerve right next to it. But my mentor, PJ, and his group down in Adelaide showed that there's all these different neurovascular branches, these little microforamen that come out, all these little dots. And they published this. And the interesting thing over here, this is anterior and this is posterior. As you can see, here's the eustachian tube. And so at least in this specimen and several others that they looked at, the majority of these microforamen with parasympathetic nerves came out posterior to the sphenopalatine foramen. And that's important when we look at success rate. So just talked about the Wormald study. This is the paper. And what's interesting is our good friend Mas Takashima and his colleagues published this paper essentially on failures that had PNN ablation with Clarifix or Ryanair. And they found 67% of the patients who were treated in the office for this with those two systems had an unfavorable attachment of the middle turbinate. And of non-responders, 90% of those had an unfavorable attachment. So what does that mean? And they included a nice CAT scan. So here's an axial scan, and you can see on this scan right here, here's the middle turbinate attaching posteriorly, the sphenopalatine foramen is anterior. That's favorable. And it's favorable because if you stick the Clarifix or the Ryanair in, you're going to wedge it right in that posterior attachment right here. That's where it's going to go. However, in an unfavorable attachment, like over here, where the middle turbinate attaches anteriorly to the sphenopalatine foramen, you're going to put that Clarifix or Ryanair anterior right here, and you're going to miss these microforamen that come out through the sphenopalatine foramen. You might even miss the main nerve that comes out right there as well. So that's something that really changed my approach and my thinking about the PNN. And not only my approach, but fortunately, there's this company called Neurant who developed the NeuroMark. And the NeuroMark is really intended to deliver more micro lesions to a greater surface area to hit more of those branches of the posterior nasal nerve. And I'll just show you a couple things here. So it uses bipolar RF energy. It's safe. It's been shown to be effective in the clinical trials done so far. It's very low power. So 1.9 watts versus 25 watts, which is what most of our devices use. So it's low energy, and it uses this really neat impedance algorithm. So there's two things. When you apply the Neurant into the nose, it's going to go through this sequence where it's going to measure, is it actually contacting tissue, and can it deliver appropriate energy to that tissue? And you get this feedback on the monitor that you're looking at, which is down here. It'll turn blue when the leaflets are in appropriate position. You see this anterior middle leaflet's not turning blue. And so you know that that leaflet's not making good contact, or it's covered with mucus or something, but it's not going to deliver the proper energy, which is totally fine when you're doing the procedure. You just, when you want to reposition, you can just move it a little bit. And so this smart console helps you direct it to not so much the best location, but it reinforces that you're delivering the energy in a proper atraumatic fashion. And it creates 20 microlesions per side if all 5 of the leaflets get deployed. This shows a little animation, and unfortunately, it doesn't light up in this bright blue, because that would be kind of neat to see on the screen when you're doing the procedure. But this just signifies that it takes turns delivering the energy to each of the micro leaflets, which is another thing that makes this easier than some of the other devices, because it's delivering this low energy, low watts, like we talked about, to several other areas, rather than just blasting one area with the full 1.21 gigawatts, if you know the reference. And that really helps minimize the patient discomfort during this procedure. While you're doing it, the leaflets will turn from blue. Sometimes it'll be a orange, depending on which software update you have. And that means that it's getting the energy, or it's in the process of getting energy. And then when that leaflet has delivered what the algorithm determines to be the proper amount of energy, not too much, not too little, just right, a nice Goldilocks setting, it'll turn green. And then at the end, you see this summary slide that shows you, hey, all the leaflets are green, or 4 out of the 6 are green, or 5 out of the 6 are green. And that's going to be good enough. So now that you kind of have a background of this, and the participants on the webinar do, Mike, I want you to take me through your average NeuroMark procedure, meaning what time of the day do you do it? Do you line up a series of them, or when do you do it? How much time do you allow for this? And do you, and then tell me about your anesthesia protocol while you're doing it.
Yeah, so I typically will allow 30 minutes, and 20 minutes of that is anesthesia. I allow 10 minutes for the procedure. I don't have a particular procedure day, but what I'll usually do is back up my office hours, depending on the number of procedures that I have. So I'll sandwich in between surgery in the morning and office hours in the afternoon. You could conceivably do this in the course of your average office day, but you'd have to set that up as 2 15-minute slots, or however you do it in your template, but 30 minutes. And so I'll have the patient comfortably in a chair, and normally during an exam, I necessarily ask patients about comfort, but since they're going to be sitting for 30 minutes, I want to make sure they're comfortable, particularly adjusting the headrest so they can sit in a comfortable position, but also in a position that gives me the best access to them. I use a topical ponocaine. I've actually got a compound pharmacy that makes a ponocaine gel. I've found that with different atomizers and sprays and liquids, some of that goes down the posterior pharyngeal wall, and it creates a very uncomfortable anesthesia to the point that patients feel like they're choking because they can't feel airflow or they can't swallow, and that's just a lot of drama. So I try to avoid that. So I will use cotton pledgets, and I will soak them in neosynephrine, and then I use topical ponocaine. I'll do the first application on each side. I'll leave it for 10 minutes. I come back, I take it out. Now the nose is more decongested. I'll do the second application, and I'll actually concentrate on getting it back. So the first one I put in with a headlight and spectrum. The second one I put in endoscopically, and I get it back to the area on the lateral nasal wall that I want to treat, so I can get it more posteriorly. And now let that second application sit for another 10 minutes, and then I'll take it out, and then we'll do the procedure.
So you're injection free, correct?
Injection free, yes.
Yeah, it's interesting. So am I. So I'll, similar to you, I use 10% tetracaine. It's this 10% tetracaine pluronic gel mixture from my compounding pharmacy, and it's probably very similar to what you use.
Yeah.
I'll have my medical assistant spray just with Afrin and lidocaine and put some lidocaine soaked cotton in the front of the nose. Usually within 5 minutes, I'll come in, and then under endoscopic guidance, I'll squirt the tetracaine into the back of the nose. Same way I would do it for balloon dilation, the eustachian tube, or even sinus balloon dilation. And I'll leave it there for a full 15 minutes. I'll counsel them, definitely do not swallow it. If you feel it dripping down, which it shouldn't because it's more of a paste consistency, I'll tell them to spit it out. There have been 2 patients of mine that have had challenges swallowing for 2 hours afterwards, and so that's not fun. So I'm pretty uptight about counseling them now about not swallowing it or snorting it down. I'll generally do one of these before lunch and then one at the end of the day. And it just gives me, I do block out 30 minutes, 15 to 20, then I'm up, 5 minutes per side. But it gives me time afterwards if I need a little bit more time or not. And it just takes the stress out of it for sure. I'm interested, do you talk to your patients about complications related to this procedure at all?
I do. Let me back up and say one more thing about anesthesia. It's just make sure you give it time to work. I do a lot of in-office procedures, eustachian tube dilation. I'll do nasal valve procedures and in addition to posterior nasal nerve. And I think the big mistake that we make a lot of times is we get in a hurry and we don't let the anesthesia work. And so when the patient has a bad experience, it's really not their fault. They're not a bad patient. We just didn't do a good job, and we weren't patient enough to let the medication do what it's supposed to do. So that's why you and I both, we give 20 minutes, and I think that's adequate. So I think that's important. So I do talk to patients about potential complications. They ask about, well, what about post-op care? And in that discussion about post-op care, we'll talk about complications. Usually the one I mentioned is bleeding. We're going in the nose with devices. I mean, theoretically, you can have bleeding from the septum, from the inferior turbinate, from the middle turbinate, but you can certainly have bleeding related to the device itself and the deliverance of the radio frequency energy. So epistaxis is one of the things that we do talk about. You know, thankfully at this point, I've not had a bad complication with epistaxis. I think part of it is the low amount of energy that's delivered, like used in the Goldilocks reference. It's just right. So I don't think we're burning too deep. You're not going to get mucosal sloughing and exposure and then opening up of a vessel with epistaxis.
Yeah, true. And, you know, I'll bring up a different study from Mas Takashima that did look at complication rates, and the vast majority of the complications used the other devices. It was interesting. They found about a 2% risk of significant epistaxis that required intervention. And the mean time to that was 3 weeks. So it's not just related to a mucosal tear during the procedure. You know, something's
Right.
going on. You're like you said, mucosal sloughing afterwards, maybe a pseudoaneurysm or something where probably the posterior septal artery is just getting blasted a bit too much.
Yeah.
All right. So this is a case just to show this is a easy side, right side, nice straight septum on this side, middle turbinate straight ahead. Left side, middle turbinate, it's tight. The septum is quite deviated now, and there's a large septal spur, same patient. So challenging case if you're going to use a rigid instrument that doesn't have much flexibility. This is just showing the delivery of the tetracaine to the right side. And I'll take it all the way from the back all the way up to the front of the nose. And then here I'm deploying it. It's called the outback technique, kind of deploy it in the nasopharynx, and then you pull anterior, and the leaflets will just hug that middle turbinate. And I'm going to pause it right here. Mike, you can see that I'm below the device. So when I do this, I use a 30-degree endoscope. And for whatever reason in my hands, I like having the device on top and the scope down below the device, which is completely opposite of how all of us, and I do sinus surgery with the scope on top, instruments down below. But I like this way because the patient's sitting up, they're not laying flat, and I can get the scope underneath the device so that I want to confirm I'm not around the torus tubarius, I'm not around the eustachian tube. What scope do you use, and do you position yours differently than this?
I typically use a 0, and I have scope on top. If the anatomy is challenging, I'll use a 30 underneath. So I think you've got to be able to do either of those, because depending on the patient's anatomy, you've got to adapt, and you want to be able to see where the device is and where the leaflets are.
Great. All right. So it's actually deploying the energy right now. That's as exciting as it gets. So, there's no burning. Now here we're on the left side. And I'm going to put the device on the top, and I'm going to slide it posteriorly. And now the scope, 30-degree scope, is going along the floor of the nose until I can now pick up the device. I'm going to open it up right at the choana, and then I'm going to pull forward. I know I'm not touching the torus tubarius, and the leaflets are going to find their way. They're going to work their way into that middle attachment area, both posteriorly and anterior to the middle attachment, the middle turbinate. And it's almost like using the force with your blast shield down. You don't have to see where you are as long as you know where you're not. As long as you know you're not touching the torus tubarius, the leaflets know to deliver energy on the patient's left to the right side leaflets. And that's one of the reasons that I really like this device more, because with the other devices with this big septal spur, and you see it just coming into the superior view there, it'd be really, really tough. Mike, any other reasons that you've kind of switched to using the Neuromark as opposed to the other two devices on the market right now?
I think you highlighted the anatomy issue. And so if you're in that pocket with some of the other devices, you're too far anterior. The other thing and I did try the Ryanair device a couple of times, and I'll admit maybe I'm still on the learning curve with that. But when I tried to, and it's malleable, but when you bend the shaft, it changes the position of the tip, and you really can't bend the tip. And so my challenge was getting good apposition. I felt like I had the device bent to accommodate the anatomy, except for the very tip, and I really couldn't adjust that. So I felt like I was not getting good apposition, and therefore I wasn't getting adequate treatment. And with the array with the leaflets and the electrode array, you're going to get good apposition with that.
And just in case someone's watching who is a Clarifix user, do you get any ice cream headaches with the Neuromark? Have you ever had one?
The only headache I had, and it was actually recently, but it was after I applied the anesthetic. And so I'm still kind of scratching my head about that one. So it was before even energy was delivered. And so I've not had an ice cream headache with Ryanair or with the Neuromark device.
All right, that's good, because the answer is supposed to be no. You don't get ice cream headaches with it like you said. So appreciate you working your way there.
Yes.
Yeah. All right. So outcomes with this device. Mike was one of the authors, as was I. Doug was the primary author. And so we published this as 36 patients, not a large study, but larger than the Clarifix study. And it showed somewhat similar results. So 53% improvement in rhinorrhea based off the TNSS, 55% improvement in nasal congestion, And that was a really nice surprise. So now these patients are coming back. Not only do they have less postnasal drainage, but they're breathing better through their nose. And then overall, just a 78% responder rate. So that means a greater than 30% reduction between baseline and 3 months. And certainly the study is ongoing, but this is the first study published with this particular device. How has this, Mike, how has this device changed your treatment algorithm? And I think the answer is you no longer send these patients to the allergist, but I just want to ask you,
Well,
how
yeah,
has it changed?
we talked about this a week or so ago I was with some of the other physicians that are using this product, and it's a paradigm shift because we never thought of rhinitis as a surgical disease, and the number of people that have actually done a video neurectomy is few and far between, and those that have only done one or two, and so that was the surgical option in the past, and that was a big deal, and there were potentially lots of complications with that, and so you just never thought of this as a surgical disease, and now it's an option, and it's a good option, and so I think it has really changed the way I look at these patients, because now I feel like I've actually got something that I can do, that I can offer, that can provide really substantial relief.
Yeah, I'll second that. And also by saying it's an easy procedure to do, right? Especially when you anesthetize the nose enough. And as you said, the key to success with that is giving it time. A solid 15 to 20 minutes. I've tried to cut back. I've tried to go to 10. It definitely was not enough. So there's that magic number, 15 to 20 minutes is important. And we kind of covered this, how we've come full circle to shooing away patients with rhinitis and really just not even writing it down in the EMR. Like, sure, whatever, postnasal drainage, but let's talk about your sinus pain and pressure and fatigue and nasal congestion. And now we're talking about rhinitis. And I think it shows that has been a paradigm shift, as you mentioned. All right, so now we are, guns blazing, ready to do this. And we want to get it authorized by an insurance company. So as of January 1st of this year in the US, we have a new code. The CPT code is 31242, which is destruction of the posterior nasal nerve with RF energy, specifically with RF energy. And not looking at the numbers below. So I've never been super impressed when a company sends me what I should make or ought to make based off a CPT code, because that's not what comes into my office ever. That's an average, and it's nice to know the average, but especially with commercials and Medicare, Medicaid, it's so variable based off of the state or the county or the environment that you work in. I just want you, how do you approach this 31242, this new code that we have, Mike? Is it a good thing? And when do you get excited when a patient comes in and you can use this brand new code we got, or is it a challenge that we're starting to work through?
It's kind of all the above. It is a challenge. When there is a code that's been released, then we are obligated to use that code if we're doing that particular procedure. The unfortunate thing about codes, and I think probably most of you know it, unless there's people on this call that have just really kind of gotten started, a CPT code does not equal payment, and that's with commercial payers in particular. And so where we practice, or I practice in Alabama, we have a dominant payer that they considered balloons experimental up until like 5 years ago, which is ridiculous. And it'll probably be the same thing with this, is with that particular payer. It may be a while before we are actually getting reimbursed for this. So you've got to use the code because the code exists. You can't use another code. We used to use 30117, and I think that's not appropriate to use that code at this point, since we do have a specific code for this currently. One thing I would say is for people who are maybe anxious or interested in trying this, because if you go back to the Venn diagram that shows particularly the overlap between non-allergic rhinitis and anatomy, some of these patients we may be taking to the operating room and doing a septoplasty and maybe some sort of turbinate reduction. And these patients may be appropriate for posterior nasal nerve ablation. If you're doing that in the operating room, that would probably be a good opportunity to become familiar with the device. We are currently trying to get it commercially available in our ASC. I can let you know in a week or a month or somewhere down the road how successful we've been at doing that. But I think that's a great place to become familiar with the device by putting it and using it in combination with maybe some of the things you're already doing in the nose.
Right. Great. So when 31242 came out, I was excited, but also apprehensive. I knew what was going to happen. I knew Medicare was going to cover it. So that was fantastic. I had lined up a few patients who had Medicare for this procedure. It's an automatic pass through. You don't have to stress about it. And these patients do very, very well. On the flip side, just with every new code, doesn't matter if it's RF for the nasal valve or Latera or balloons, it's always a struggle. And it's going to be a struggle for another year, year and a half. And that's just how the new codes happen. And the payers will just kick the can down the road as long as they can until the patients start complaining. So if 31242 doesn't get approved, and it's considered investigational, there are options. And we do offer a cash option in my clinic, but also in our ASC. And Mike, I'm glad you brought it up because you're right. Someone looking at the case that I showed with a severe deviated septum, they were probably thinking, why didn't you just take him to the OR and fix the septum at the same time or cut out that septal spur? Or she was on Plavix and really sick and did not want to go to the OR. And I didn't want to take her to the OR either. So I have done this on patients on blood thinners. I try to have them hold it if it's Plavix, for 48 hours ahead of time. That patient was adamant she was not going to go to the OR. So it is just a nice case that shows you can do it around a septal deviation. But for us in the ASC, it reimburses very nicely from Medicare. Medicaid's a completely different story, and it's frustrating, but Medicaid will reimburse differently depending on what state you're in, and sometimes which part of the state you're in. And so for several things that Medicaid covers, it doesn't even cover enough to pay for the device. So you have to think about that one. But if you are a practice owner and you have the ability to bring in cash to your practice, this is a nice option. And, you don't need to charge a ton. You know what the cost of the device is, and you'll add a little bit for your time. And I've had several patients fortunate that they can do that. One of the things that has helped dramatically, and if my nurse was on the line, she would give a lot of praises, is to this. It's called MyMark. And this is a portal that you can use. It's online, and your staff can put in the data, and it sends this out to the support team that will do the insurance pre-authorization. And that's been a huge benefit for us, because with these things where you're trying to get authorization from insurance companies and then you're appealing it, it takes a significant amount of staff time. That's uncompensated staff time. So this has really streamlined the process. My nurse loves it, and it's taken a lot of work off her plate. Mike, have you guys started to use this in your office yet?
Not yet. We are just starting kind of commercial cases, because most of our experience has been in any of the 4 different device studies that we've participated in with the Neuromark. And so most of ours has been research.
Okay. Well, I would encourage anybody who's just starting to use the Neuromark system, talk to their rep about this MyMark system, and it'll just sets the tone. It just makes it quite a bit easier. So at this point in time, we don't have any questions we had one that we answered. If there's any questions, feel free to write them in our final moments here. Otherwise, Mike, do you have any closing comments on people who are just thinking about using Neuromark?
Just your last description of MyMark, it's a lot like some of the biologic companies have the same sort of services they offer to help with those pre-authorizations. And it really is a resource that takes it off of your staff, because I know, we have a small office we have a small staff. Everybody's wearing lots of hats. And then when you throw one more pre-authorization issue at them, it's just hard.
Right. There's a question came in asking about how much we charge for cash. I think I'm happy to talk to you. Anyone wants to email me. It's just gregdavismd@gmail.com. I'm happy to talk to you one-on-one about that rather than put it out to a recorded webinar because things may change. And David, thanks for sending in your question from Spokane, Washington. Can you bill a 30801 for treating the turbinate? So 30801 is superficial RF treatment of the inferior turbinate, just like we would use the Vivere device. Could you probably could. It would certainly be off label. And personally, I always hesitate to use a device or at least code for a device that's off label. I think you would likely be fine. It certainly is RF treatment to the anatomic site. But again, the neuromark hasn't been studied to treat the inferior turbinate, it hasn't been published to treat the inferior turbinate, and there may be some unwanted risks associated with it. Mike, what do you think about that?
Yeah, I agree, because I think with it being a lower wattage device, you may not actually deliver enough energy to adequately treat the inferior turbinate. So I don't know, like you said, it's not indicated for that. It's an off-label use, but even if it were in its current design, I'm not sure that it would deliver enough energy to treat the inferior turbinate.
It is interesting, though, that you see a decrease in the nasal congestion on the TNSS, with the neuromark.
Right. Right.
It's treating something that's causing an improvement in nasal congestion. So whether or not it's decreasing the size of the middle turbinate, it's tough to say, because it does not have leaflets that come into direct contact with the inferior turbinate. At least that's not the intent.
Yeah.
Also from wonderful Spokane, Washington, Mike Cruz. Thanks for asking this question. Is there any role for performing PNN ablation in a patient who has CPAP-related rhinitis? Yeah, nice question. I haven't, there certainly hasn't been a study that I've seen about that. I think, we know these devices work for allergic and non-allergic rhinitis, so I don't see any reason why it wouldn't. Mike, do you have any thoughts about that?
It's interesting. I think some of the patients that I have treated for, quote, non-allergic rhinitis have been on CPAP. And so I don't know that we attributed their rhinitis to their CPAP, but so many people are on CPAP. It'd be interesting to go back and look at some of our studies and see if we could tease out how many CPAP users we've had. So I think it is a non-specific, non-allergic rhinitis. I don't see why you couldn't try it in that setting, but like you said, it has not been studied.
Right. And, CPAP is an irritant, just like any other irritants we've talked about. Pollution, forest fire, smoke, strong chemicals, strong perfumes. I would see it just, although it's a pressure sensation, but I'd be encouraged, Mike Cruz, to take a look at that and go for it on your patients. All right. Well, with that, we're likely going to end a little bit early, and no one will complain about that. But I'd like to bring Brian Shields back in from Neurant. And Brian, thanks for having Mike and me on board. We always enjoy talking about this, and I'll turn it over to you.
Thank you both for what was a very informative session. I think everyone would agree. I might pass the 1.21 gigawatts of energy reference back into the R&D team. Pretty confident, Greg, that they won't get the reference and they'll correct it. But excellent talk. Very enjoyable to hear you guys speak always. So thank you very much for that. And with that, I think we can close the session.
All right. Have a good evening, everyone.
Thank you all.
Thank you. Good job, Greg.
I'm going to go backstage, Mike.
Okay.